I will be talking now about teaching in the operating room. I will ask the other speakers that if something I'm showing doesn't show or anything, they just let me know through the microphone. Okay. So I have no financial interest to disclose. And the objectives of this presentation are that by the end of it, sorry, I'm having trouble. Let's start this again. There we go. We should be able to discuss principle and develop guidelines to work in the operating room with our residents. So the questions that we should be answering by the end of it is, what principles could we follow in building guidelines for teaching in the operating room? And what guidelines could we follow to have an efficient and effective teaching system in the operating room? So now I will start this poll. Go. So now I would like to know which is your position in the hospital or program you're in. Are you a resident?
Eduardo?
Yes.
Eduardo?
Yes.
I can see the slide. Oh, there it is.
Okay. Thank you,
Sorry,
Ravi.
the poll
Yes.
wasn't being shown.
That's correct. So then I can have an idea. Okay, I'm getting 22 out of 47, 23. Okay, so I'm going to take a look at the answers and share the results. So we have 39% that are fellows or trainees, 39% that are trainers in surgery, and 21% other that probably do not train residents in surgery, but probably yes in other topics. Another survey. Now, what I would like you to tick on, and I'm launching now, this is not a multiple choice question. Here, I'm asking that you list from most frequent to less frequent the following barriers. Probably all these barriers appear in every residency program. And what I'm asking is you rank them from the most frequent that negatively affects teaching and learning surgery. So now, the first thing you have to do is look at the list, choose the one you think is first for you, go to the down arrow that is beside it, click on it, and then put a 1 in the one that you think is the one that more affects your teaching. And then with the rest, go down and order them in that way. Okay. I see many are answering. This is an interactivity that's quite difficult to answer, because sometimes it can be a little bit confusing. Okay, we've got enough answers, so I will end the poll and now share the results. So if you look at the one that was most selected, you will see all the answers there. At the bottom, you get numbers 1, 2, 3, 4. Those are the colors. What this means is that, for example, fear of having complication was selected as number 1 from most of you. The second one, 2, is the violet one that I think very little were chosen. And the least one is number 5, unexplained willingness of trainers to collaborate. Okay, thank you very much. Yes, lack of time during surgery probably is the most important barrier. So now what I would like to know, if any of you have found or have another kind of barrier. Please answer this through the question and answer icon. If you feel that in between these, something is missing. If I get no answers there, I will go on. Okay, it looks like we've covered most of the reasons why we have trouble teaching in the OR. So I will divide my content into 3 big parts: during surgery, before surgery, and after surgery. This last one will not be, we will not go over it today. This will be next week. So another point. What do you think is the most important role of the instructor in surgery? Okay, answers are coming in. More people are answering. Okay, good. So I will end the poll, share the results, and the most chosen answer was prevent complications, then make sure the resident can get enough practice time, and then fix complications. So this was a tricky question because really all of these are things the trainer should take care of. But I agree that the main one is prevent complications. So the instructor's main objective is to prevent complication. This is protecting the safety of the patient. And as it is said, it is better to prepare and prevent than it is to repair and repent. Another question: how many times do you change places with your new resident during surgery? This means up to how many times you have changed places in one surgery with the resident. Someone you only change once, sometimes you're able to change 2, which is the most often number of times you change with the resident. Let's go to polls, back. Let me find it because they're not in order. here, lunch. Okay. Okay, answers are coming in. Good. So I'll finish the poll. I'll share the results. And so most of you do twice. Then some of them do more than 3. That's very good. Then 3 and then 1. So it looks like you are prepared to do this. And this is a good thing to do, because the more you change, that means the more opportunities you give your resident to learn. So let's go back to the first principle, preventing complication. I've been to many residency training programs where the instruction technique is wait for the first error or complication, then the resident has to stand up and you finish the surgery. This can be probably good for the patient, but not good for the resident. For 2 things. First, the doctor is waiting to have the resident complications to change places. And second, he is not giving him the opportunity to keep on going if he were to prevent the complication. Instructors should anticipate complications, change places, show the resident the right way to do it, and then let him or her sit back again. Resident and instructor should change places as often as needed, respecting the maximum time allotted to that particular surgery, and I will be back on this concept in a minute. For example, if you see the capsulorhexis is going too near the iris, before it goes under it, change places, bring it back, and then let the resident continue. If you see the resident go spearfishing nuclear fragments into the capsular bag, switch places, show him or her how to float the pieces into the anterior chamber, and then let them continue. The 2 biggest threats I faced when training residents were overconfidence and speed. Always, my favorite learner is the one that comes with me for his first surgery. These will be the most cautious ones, and that will be better follow any instruction. The ones I fear most are those who have already been many times to the OR, and especially those trained by surgeons that do not put patient safety first. When one becomes overconfident is when complications start, as it happened to this motorcycle rider that was winning the race. The second one is speed, the second threat. Residents try to replicate what they see experienced surgeons do, and usually experienced surgeries do their surgery fast. My belief is that when trainers can anticipate most of the complications and prevent them if the trainee is doing things slowly. I always tell my residents, do every step in slow motion. This usually gives me the time to have that stop, correct, or let me take over before the complication happens. Another thing you have to do to handle the many times the short time you have to teach is, first of all, define how much should the surgery take. If it's 20 minutes or half an hour, then that once that is defined, you will know how far will you let your resident do the surgery. And then look ways to optimize your time. How do you think that we can optimize surgical time? Use the Q&A box to answer this. I see nothing going in, probably Well, I hope you all found the icon for Q&A, and maybe, okay, here one came in. Properly selecting patients, practicing more and more, perfect. Avoid unnecessary movements. Okay, so let's see what I have to say about this topic. So the first point I would like to point out is that assign wisely your patients. Each time a resident sits down as a surgeon, he or she is taking away an opportunity for another resident to practice. If you assign a case to a resident that does not match the needed abilities, the teaching opportunity is lost for him because you will not let him go on, and for some other that probably was more capable of doing this surgery. Remember, assign wisely, match residents' abilities and eyes. For example, match right-handed residents to right eyes and left-handed residents with left eyes, when possible. Assign hard or soft knuckles to more experienced residents. And if you have a resident that's a first-year resident and not able to handle it, let him do any other part of the surgery, but not this. Also, with super difficult cases, first thing you should have to decide is this resident able to handle this without complications? And then let it go on. Fortunately, even in difficult cases like this, any resident can do some of the steps, like, for example, the incisions and putting in the viscoelastic, etc. The second thing you should do is choose the steps. There is no need for a resident to do all the surgery. Let new residents start with the steps they are able to handle. Prioritize steps that cannot be practiced adequately in the wet lab, and combine beginning residents with more experience. Many times you can have two residents, one a junior, one a senior in the operating room, and many times you can have them do one part one, the other part the other. The other way of optimizing operating time is have them practice in the wet lab as much as they can. Don't let residents do a step in the operating room until they are proficient in the wet lab. There is no need to have expensive equipment to do this. There are very inexpensive practice microscopes, and with very few instruments, most of the surgery steps can be practiced. If the residents come to the operating room with well-developed and trained hand-eye coordination, patients, instructors, and themselves will benefit from this. Second or third, assign more than one surgery in a row to a resident. It is better for a resident to perform 5 surgeries on the same day than one each day in different days. This is because feedback given is more fresh and there are more possibilities that they will apply it in the successive cases. Let's go now into communicating with the resident. No matter what disclosure was given to the patient about the resident participation, we do not want to create anxiety in our patients during surgery. Saying things like, stop, you're going to break the capsule, or don't do that, do this and this, or that was a dangerous thing. At the same time, we do need to communicate with our resident. Here comes another question I would like to. Let's look for the pause. So, how do you communicate during surgery with your residents? You give instructions openly, you give instructions in a low voice, you don't give instructions at all, and other. Okay. Several answers coming in. Let's take a look at the results. So many give instructions, most of you give instructions in a low voice. Some of you give instructions openly, and this could be okay. It doesn't mean that giving instructions openly is bad, but your patient should be prepared for this. You don't give instructions at all, well, that is another way to go, and other. Will those who answered other like to give what are the options I left out? Do that in the Q&A, and if something comes up, I will read it in a moment. So I will stop sharing and move on. So what I usually did, because I've been retired from surgery for a while, I always tell them, during surgery, I will be talking to you, my assistant and the nurses. When I talk to you, I will use a loud voice. When I talk to my team, I will use a lower voice. Only pay attention when my voice is loud. Anyway, probably they still keep attention when my voice is low, but they're not asking all the time, what did you say? And the other thing is, for me to be able to give an instruction and not alarm the patient, what I do is use some kind of code. For example, if I want the resident to go slower, I say, set the phaco to a lower speed. This, for the patient, is just listening to me to give an instruction to the nurse to set up something on the phaco. If I want the resident to deepen the groove, then I say, set the phaco for the deeper groove. If he's displacing the nucleus, I say, help me keep the nucleus centered. And if the rhexis is going wide, I say, set the rhexis for a smaller diameter. So having these kinds of coding to speak gives the resident exactly what you want him to listen and change, and does not alarm the patient. So what about before surgery? Before surgery, you must make sure you know your resident well. And this is not always possible. Many times a resident is assigned to you, probably sometimes it's for the first time, or if he was with you, it was a long time ago. So use the scrub time to get to know your resident. Where is he? What are the difficulties he or she have, etc. Second, make sure your residents know the theory. Give them books, give them videos to watch, give them guides to watch. And if so, after the resident tells you what are the steps he has more difficult on, just question him on some techniques and strategies to make sure that his knowledge is enough to participate in the surgery. Applying adult learning theory here is also very important. You will say residents don't read the theory, or they do not remember what they read. That is true. Many times that happens. So what you have to do is point out the relevance for that. I usually do my best to encourage them to study. They will learn more rapidly if they realize that this will be useful to them in the future. And learning is more effective when students can apply theory to practice close to it. So it's not good to read a book today and 6 months later go to surgery. When you can apply it immediately, it's better. So what I suggest is that you look at this list of surgery for the next week, and then you take a look at what are the cases, and you send your residents to read about those, especially if they're going to be complicated cases. And then you discuss with him which other techniques you will be using, which will he have to do, and then you can compare what you plan with what happened in the surgery. It is also good that even if you give this task to a resident, this also could be discussed in a group. Time, as we said before, is a problem, and learning is enhanced when adults have control or influence over their educational experience. So this is why it is important that they let you know what are the problems they're having, what they would like to do in this surgery. Let them choose whenever possible. And always don't let them go too further about the comfort zone, but pushing them a little bit is a way of practicing. This is a very important topic, that disclosure of resident participation. And now I would like to know, how do you do this? Okay. So, how do you disclose resident participation? You just make the patient read a consent and sign. Or you say that he's authorizing you and your team to operate, or the resident makes the complete disclosure, or some other. Okay, we're getting still some questions. Okay, so let me finish this, share the results. Okay, so most of you, and probably, not probably, this is what I usually did, is just having him read the consent and asking him if he has any questions to ask. Many patients do not ask any question, but some, yes, want to know a little bit more who is going to operate. So in this cases, what I do is telling him, I'm going to be a surgeon. I will be operating, and Dr. X and X will be helping me. Many times I ask doctor to do maybe one step or help me with a step I'm doing, so he will also be participating in a way in your surgery. If the resident makes the complete disclosure, I think this is the best option. But as we can see, most of us do not do that, and this depends a lot on culture. What is good is that the resident gets to know the patient and even make all the preoperative studies. I have had cases when a patient comes in to be operated by me, gets into the operating room, looks around, and say, where is Dr. X and X? I was expecting him to operate me. So there are different ways, and the more you openly discuss this with the patient, the more ethical it is. So I'm sharing the results. As I said before, most of you do the same as I do. Let's stop sharing and move ahead. So related to this topic, we all know that this curve that appears here is true. The more surgeries a resident does, the less complications they get. There was a very interesting article on that was called Breaking the Silence of the Switch. This means breaking the silence when you stand up, the resident takes your place and goes operating. And these are the recommendations that were done there, that the patient should meet the trainee during the operative process, have an informed consent discussion with the trainee, know the role trainee will play in the surgery, and know the specific complications rates for the procedure. And patients are expecting this. There was another question here that asked them, how upset would you be if you found out that a resident was involved in the surgical procedure without your permission? And when this participation was just looking or being in the operating room and watching, very few would have got upset. But even assisting without their permission got more upsetting, and the most of it that they were performing surgery, where 59 would be extremely upset if they learned this after the surgery. So I will stop here because after surgery, I will talk about this on next Saturday. And let me summarize. The slide, I don't know why it went away. Let me summarize of what we've talked today, that during surgery, the main concern for the surgeon is patient safety. Operating time can be handled to have any resident be able to do some of the steps by choosing well the steps you will give them, steps they are prepared to do. We talked about communicating during surgery. I think that the best pearl I would have you take is that develop a code to be able to speak loudly, clearly, without alarming the patient. And before the surgery, make sure you know your resident. If he comes to you and you do not know him well, use that time while scrubbing to talk about how is he, where he is, what are the difficulties, and make sure they have practice and they're able to do the steps they're going to do in the surgery in the wet lab. It is very important not only to send residents to the wet lab, but to keep track of what they're doing, how they're doing it, and how good they are. Okay, thank you.